afternoon, everyone.
Good afternoon.
Welcome to today's webinar on OCT interpretation and case history. My name is Jane, and I'll be your moderator for this session. We're excited to have you all here. First and foremost, I really want to appreciate you all for honoring this webinar. And as we dive into the importance of OCT, which stands for optical coherence tomography in clinical practice, you'll be learning how detailed it is and also having a knowledge on case history and how it contributes to accurate diagnosis. So this webinar will be very informative and interactive. So feel free to drop your question in the chat box as we go along, if you have any. And we'll have a dedicated Q&A session towards the end where our speaker will answer as many questions as possible. So we're privileged to have Dr. Wisdom Obaro-Wakwe, who is an expert in the optometry field. He has contributed immensely to the teaching and training of colleagues, both students and doctors. He's currently practicing in Lagos at Air Force Hospital and has extensive experience and knowledge when it comes to retinal imaging and has worked on numerous cases involving OCT technology. So you're really going to enjoy this webinar, so just stick along. Over to you, sir.
Good everyone.
Good day, Doc.
Good afternoon, everyone.
Good
How you
afternoon,
doing?
Doc. Well, fine, thank you.
So I want to appreciate the OSA Forum for their immense efforts towards all they do in clinical dexterity. Okay, so this is optical coherence tomography. The short form is OCT interpretation. So this work was done by me months ago, but I keep updating it as I am expanding my knowledge base. So quickly, we are going to look at introduction, the types, indications, stroke limitations, glaucoma evaluation, retinal diseases, and conclusion. So this class is a basic class. I'll try to be basic as possible. We are not going to be looking at complex stuffs for now because I assume that we do not have a pre-knowledge of it so that I can carry everyone along. Then maybe in our subsequent class, I can now begin to discuss deeper matters on OCT with us. But whatever we do here is going to be adequate that you yourself, you can interpret OCT results. The introduction is OCT is a non-invasive technique for cross-sectioning tissue imaging. So what we mean is that it is non-invasive in the sense that there's nothing piercing through you. Do you understand? Some techniques, they need to pass through your body, but not in OCT. So it is a non-invasive technique for cross-sectional tissue imaging. And secondly, it uses high resolution in order to get a good picture of what it wants to capture. It is essential in organs where a biopsy is not readily available, such as retina. So there are organs you cannot just take from your body and go to the lab to examine. So in such cases where you can't do biopsy, the OCT comes in handy. Are we together? So it's also a standard tool for imaging in macular diseases, diabetic retinopathy, glaucoma, and other retinal diseases. So when we are faced with pathological issues affecting the macula, someone who has diabetes, someone who has glaucoma, retinal issues, the standard tool is OCT. It can also be used for precise choice of intraocular lenses, but that will not be my focus for today. Today, I just want us to be able to get what it is all about and how it is being interpreted. And then finally, OCT findings alone should not be used as the final tool for clinical findings because it gives you a better edge when you bring in your CVF, your fundus camera, and all that stuff. Please give me a minute. Sorry for the break in transmission. So, are you with me? There are three types of OCT. The first is a time domain OCT. The second is spectral domain OCT. And the third is swept domain OCT. So I won't be focusing so much on all this because I assume that you should already know the types of OCT. You should know them already and know the type your clinic uses. It will give you an edge to know how to interpret and how to make use of it. Are we clear? So a good knowledge of the types of OCT will help you to in your interpretation because different types have their own probably modus operandi. Are you with me? Are you with me?
Yes, Dr.
Yes,
Victor.
sir. Yes, sir.
Yes.
Okay,
Yes.
so let's quickly look at the indications. Indication simply means when do we send for OCT? Are you just going to be sending for it for every now and then? So we need to know the specific things we are dealing with to be able to know when to send for OCT. The first is when you are suspecting or it has been diagnosed of intraretinal fluid collections. When you are seeing edema, you send for OCT. Subretinal collections, glaucoma, posterior vitreous detachment, diabetes, neurological disorders, asteroid hyalosis, vitreoretinal conditions, vitreomacular traction syndrome. So do not be surprised when a neurologist sends his patients to you for OCT. You should not be shocked and say, why is he sending it to you? So I want you to know that as a healthcare professional, you are not just working in isolation. You are working with other healthcare practitioners in order to achieve a common goal. So,
Huh?
um,
Which is Nigeria Optometric Association, say no, sir. No.
so in cases of diabetes, for instance, a general practitioner might be managing someone for diabetes for some time, and then he refers to your facility for you to do OCT, because it can also not just helping you as the optometrist to know what's going on, it also helps the general doctor to know the extent of the damage caused by the diabetes. Are we together? So these are not only the indications, but whenever you see this, you know that you ought to send for um, OCT. And then the limitations. So a clear ocular media is needed for better performance. So in cases of mature cataract, some OCT machine might not be able to pick up the image it wants. But not all OCT machines anyway. But some OCT machine might not be able to pick up when there is a hazy medium. And secondly, a minimum pupillary size of 4 millimeter is required. I know in the elderly, they have meiosis, constricted pupil. So it can be a limitation. Can be a limitation. Thirdly, it is an expensive equipment. Not every clinic has the luxury of owning one. So it's also a limitation. And then finally, it requires a high level of technical know-how. So what I mean is that you will need to, not just anyone can interpret it. So it will take the expertise of a doctor and his team to be able to come to accurately diagnose and see what's going on in an OCT. Are we together? Are we together?
Yeah, yeah, with you, sir. Thank you.
So the first thing we are going to be looking at is glaucoma evaluation. Glaucoma evaluation. Um, you want to know when is it glaucoma and when it is not glaucoma, because sometimes some clinical signs we'll see and we call them glaucoma might not be necessary glaucoma, because glaucoma is a progressive degenerational disease that affects the optic nerve head. But not only glaucoma affects the optic nerve head, even optic neuritis can affect the optic nerve head. So it's good we are able to differentiate pathologies and know that, okay, why we are sending for OCT is because we are suspecting or we are sure that there is glaucoma there. Are we together? So let me begin with when it is not glaucoma. First of all, when you see a vertical field defects, we know we are not dealing with glaucoma. So because glaucoma obeys the horizontal rule. So when we see vertical field defects, we know we are not dealing with glaucoma. Again, loss of nasal retinal nerve fiber. You know, in your retinal nerve fiber arrangement, there is the superior nasal, inferior nasal, superior temporal, inferior temporal, and then the papillomacular bundles. So the superior temporal and inferior temporal are the most susceptible to glaucoma damage, and the papillomacular bundles and the nasal retinal fiber are least susceptible to glaucoma damage. So when you are seeing a loss in the nasal retinal nerve fiber layer, and then the superior and inferior temporal fibers are still intact, and likely we are not dealing with a case of glaucoma. And then thirdly, a large optic curve not equal to visual field defect. So you are seeing a large cup, and then you are thinking that maybe when you do your CVF, you will see a damage corresponding to the cup, and then what you are seeing in your thermoscopy and your visual field CVF are not aligning, likely you are not dealing with glaucoma. Again, super fast visual field loss. You know, glaucoma is a progressive um, loss in vision. So it is never super fast. So every time you see a super fast visual field loss, likely you are not dealing with glaucoma. What do we mean in this case? For instance, a patient comes to the clinic a month ago and is reading 6.5, 6.4, or 6.6, and then in the next 1 or 2 months, he can't even see 6.60. Most times, glaucoma is not the cause of that super fast visual field loss, even though it can be. But I want you to weigh other options. And then, when it is not glaucoma, is pallor in the rim, which does not match the cupping. So when pallor means paleness. So when you see pallor in the neuroretinal rim, the neuroretinal rim is the distance between the outer cup and the disc. So when you see a pallor around that area and it's not matching to the cupping, likely something else is going on, which is not glaucoma. And then finally, central scotoma or loss of acuity in a non-advanced glaucoma case. So you know, likely what we are dealing with is not glaucoma. Are we together?
Yes, doctor.
I know you have questions, but please just drop them down. When I'm done, you can ask your questions, and we'll always make reference to what I have said before now. Then, so this is a graphical the illustration of what I'm talking about. This is what we mean by vertical field defect. So if you look at this side, you'll see that there's a loss in this black part is signifying a loss in vision. But you see this place is still white. So you see that this result is respecting the vertical meridian. But glaucoma is usually horizontal. That means you see an accurate visual field loss. So this is what we mean by a vertical field defect, and this could be indicative of hemianopsia and so on and so forth. And then this is what I mean by a loss in the nasal retinal fibers. So these fibers here are superior temporal. These fibers here are superior inferior. Sorry, inferior temporal. These fibers here are called nasal fibers, and these fibers here are the papillomacular bundles. So the papillomacular bundles, they arch around the macula. They arch around the macula to insert into the optic disc. So the papillomacular bundles and the nasal fibers are least susceptible to glaucoma damage. So when you see these two fibers here, which are called the nasal fibers, you see a loss in them, and then the superiotemporal and inferiotemporal are still intact. We know we are not likely what we are dealing with is not glaucoma. And then this is what we mean by a central scotoma. So these are different kinds of scotomas. This is the aqueous scotoma, which we will see most times in glaucoma patients. But in this case of central scotoma, which is not a case of advanced glaucoma, likely what we are dealing with is not glaucoma. So now that we have been able to differentiate when it is not glaucoma, let us quickly look at when it is glaucoma. So when it is glaucoma, we are seeing a vertical overcupping with loss of neuroretinal rim. Remember I said earlier that neuroretinal rim is the distance between the disc margin and the cup margin. That space is called the neuroretinal rim. Secondly, when it is glaucoma, asymmetry of the cups. When you are seeing a different cupping, you are seeing maybe 0.7 and 0.4. There is a difference in cups. It could be indicative of glaucoma. Also, a natural shift of the blood vessels at the disc. This is what we call nasalization. It's one of the signs of glaucoma you see during ophthalmoscopy or when you do a fundus photograph imaging. And then bionetting is one of the signs we see in glaucoma. Laminar dot sign, barring of circumlinear blood vessels, splinter hemorrhage. Another name for this splinter hemorrhage is Grant's hemorrhage. It's named after the founder, Grant. Also, pallor of the disc. When you see pallor of the disc, pallor simply means a pale appearance of the disc. It's also indicative of glaucoma. And then aqueous scotoma, when you do your central visual field test, you see an aqueous scotoma is indicative of glaucoma. Are we together to this point? Are you with me?
Yes, sir. Yes, sir.
Okay.
Yeah, we are with you, sir.
So let me quickly
Yeah.
go to the next slide. So this is a graphical image of vertical overcupping. So this is what we call the optic disc. This is the optic disc, and then this is the cupping. So you can see from the illustration here, this diagram here, this straight line is trying to show us where the disc is, where the cup is, and where the neuroretinal rim is. So the distance between the disc and the cup is the neuroretinal rim, and then this is the cup. This is the cupping, and again, this is the neuroretinal rim. So when there is a vertical overcupping with loss of neuroretinal rim, we are suspecting glaucoma. So this first image here, you can see that in this first image here, you can see that there's a vertical cupping, yet the neuroretinal rim is intact. Why here? There is a vertical cupping too, but you can see that there's a loss in a neuroretinal rim. You can see the paleness around the neuroretinal rim as compared to this other image here. So this appears healthy, while this appears pale. This appears pale. So when you see this, you are suspecting for glaucoma. Also, asymmetry in the cups. So you find out that this cup in here is not the same size as this cup in here. So there's a difference. So this can be a cupping of 0.4, and this can be a cupping of 0.6, 0.7, as the case may be. So when you notice a difference in cupping, is a sign that there is glaucoma setting in. And again, the nasal sheath, if you look at this, the blood vessels here, you find out that it comes this way, and it's as though something is shifting them, something like to form a curve. So this is what we call a nasalization of the blood vessel. So you find out that the vessels are shifting nasally. Also here, if they are not straight aligned, it is shifting towards the nose region. Can you also see it here that the vessels are inserting here, but then they are shifting towards the nasal side of the cup. So this is what we refer to as nasalization. And then bayoneting. In bayoneting, you find out that the vessels, when they enter here, is as though they are missing. And then you find it again resurface here. So this is what we refer to as bayoneting. And then the laminar dot sign. So you see the lamina cribosa in this place. If the cobblestone-like appearance, if it is manifest, it's also a sign of glaucoma. Are you with me?
Yeah, we are with you, sir.
Okay, now this is a case of splinter hemorrhage. You see like a splinter here. So this thing here is a hemorrhage. So you might not see it in all glaucoma cases, but when you see it, it's also indicative of glaucoma. And then this is pallor of the disc. Pallor of the disc is a paleness or a shiny whitish appearance of the disc. So you see that the disc is appearing as if it is pale. So it could be indicative of optic atrophy, can also be indicative of glaucoma. And then this is what we call aqueous field defects, as seen in perimetry, indicative of glaucoma. So you see early changes, early vision loss in this patient, unlike the previous one I showed you, where it was just in the obeying the vertical hemisphere. So quickly, let's go to the OCT proper. The following in glaucoma evaluation, the following are critically observed during glaucoma evaluation. First of all, we want to look at the retinal nerve fiber layer and analyze it. We want to look at the optic nerve head. Remember, glaucoma affects the retinal nerve fiber layers. It also affects the optic nerve head. Also, finally, in advanced cases, the macula can be affected. And also, we want to look at the ganglion cell complex analysis. So these are what we are looking at when we are dealing with glaucoma evaluation in OCT. So quickly, the retinal nerve fiber layer analysis. The retinal nerve fiber layer is formed by the retinal ganglion cells. So if you remember the layers of the retina, the ganglion cells come together to form the retinal nerve fiber layer. Fibers from the nasal half of the retina come directly to the optic disc as superior and inferior radiating fibers. Short form is SRF and IRF. I will show you a diagram of this after now. and those from the macular area come horizontally as papillomacular bundles, PMB. And fibers from the temporal retina arch above and below the macula and the PMB as superior and inferior arcuate fibers, known as SAF and IAF. So glaucoma is the number one cause of nerve fiber layer loss. Glaucoma is the number one cause. And remember, the glaucoma usually affects the temporal fibers first before the nasal fibers. So this is what I mean. These fibers here are called the superior arcuate fibers, and these are the inferior arcuate fibers. These are the papillomacular bundles. If you notice, they arch around the macula to insert into the discs, and these are the superior radiating fibers and the inferior radiating fibers. So glaucoma usually affects the superior arcuate fibers and the inferior arcuate fibers first. So it's now when we get to end stage, and then they begin to affect the nasal fibers. This is why you see tunnel vision in advanced or end stage glaucoma. So components of the OCT scan. The following are the components. The first component is the patient data. The first component is the patient data, and it involves the name of the patient, full name, the age of the patient. The age is very important because OCT, built into the OCT, are age grades. So the machine, beyond just checking your eyes, is comparing your data with that of your age grade. For instance, if you are 50 years of age, it's not just comparing what your eyes is showing, but in correspondence with other people who are of the same age with you. Are you doing well when compared to them? So the sex also is noted, either male or female, and also the date of the examination. Very, very important, because you might need to do another OCT result, and another test rather, and we need to compare what you did the last time and what you are doing now. So the date is very, very important, and also the timing. The date of birth also is important, the registration number, and the refractive error. So most times, for some machines, people who have high refractive error, their result might not appear so fantastic. So this is why we need to also note the refractive error we are dealing with in this case. I'll talk about that later. And the second component of the scan is the scan quality. The scan quality. So the following factors can affect the scan quality: an inaccurate date of birth. So assuming the patient is 60 years of age, and then you mistakenly impute 40 years, you can have an inaccurate scan quality, because the OCT is an imaging test. So the higher the quality of the image, the better the results and the more reliable it is. So assuming the patient is 40, and then while imputing, you mistakenly impute 60, you are likely to get a wrong result. Also, poor signal strength can affect the scan quality. So for some machines, from 6 and above is a good signal strength. The signal strength is from 1 to 10. So for some machines, anything 6 and above is a good signal strength, and 5 and below is a poor signal strength. Also, movement artifacts can also affect the scan quality. Media opacities, opacity in the cornea, opacity in the lens, opacity in the vitreous can also affect the scan quality. The age of the patient can also affect the scan quality. The race, Black Americans or Africans are more susceptible to glaucoma. It can also affect the scan quality, and also myopia can also affect the scan quality. Are you with me? Are we together?
Yes.
Yes.
Okay.
Yes.
So I assume you have followed to this point. Remember, just don't worry, this is a basic class. Subsequently, I might have to repeat it again and then introduce something more advanced than this. But either ways, I'm sure you will get one or two from this basic class. So components of the scan again, the third component is the retinal nerve fiber layer thickness map. It is the tomographic map taken over the retinal nerve fiber layer to get its thickness. The thickness is represented in an hourglass or butterfly shape. which is usually red or yellow in color, indicating normal thickness. It helps us to detect the asymmetry between the superior and inferior quadrants and can detect early peripheral defects. So sometimes you can do CVF and then the machine will not detect early changes. But then when you do your OCT, it can detect even the minute changes. OCT can detect it. Also, peripheral defects will appear bluish, greenish, or black in extreme cases. The color coding of the thickness map is opposite to the deviation map. So I want you to know that the color coding, this test will be dealing with a lot of color interpretation. So the color coding of the retinal nerve fiber layer thickness map is not the same when we are dealing with the deviation map. Are we together? So this is what I mean. So this is an image of a normal retinal nerve fiber layer thickness map. So the retinal nerve fibers will appear as butterfly or wing shape. So what we mean by butterfly, this where my cursor is going, you can see it also below. This is how what a normal retinal nerve fiber layer thickness map will appear, and this is the color coding. So from here to somewhere here, that is from red. If you notice, the color it changes as it's going down. So anything blue is showing bad results, and black is showing extreme cases that there is a loss there. So this is an image of an abnormal retinal nerve fiber layer thickness map. So you find out that compared to the initial one, which is this one, you see that this place is yellow and there is red somewhere. So which means the layers here are still healthy. So the here that is red is indicating that it is more healthy than where there is yellow. But yellow is still acceptable. But in this case, you find out that we have less yellow. We can virtually see no red or pink here, but you see blue almost everywhere. So this is indicative of an abnormal retinal nerve fiber layer thickness. Are we together?
Yes.
So the fourth component is the RNFL deviation map. So this represents a statistical plot derived from the RNFL thickness map. This compares the patient's RNFL thickness deviation with that of the age match normative data in the machine. So what we are trying to say is this, that in the deviation map, it is not just saying this is what you have. It is comparing what you have with that of your age grade. It is just like boxing. There's their weight grades. So if you are not under a particular weight category, you cannot fight in that category. Are we together? So the machine also has collected data from what normal looks like from other age grades, and then once you input your own age grade or the patient's age grade, it's now comparing what is obtainable for that age grade with the patient's age grade. This is why the patient's age is very important. Make sure that the patient's age is correct, because if you put a wrong age, they are likely to get a wrong result in the deviation map. Also, areas that are within normal limits or thicker than normal are not marked on the map. Areas that are thinner than normal are marked with yellow or red color, with red being more severe. Remember, in the retinal nerve fiber layer thickness map, red is indicative of a good result. But in the deviation map, red is indicating a poor result. If the patient's normative data are not in the machine, it can also appear as an artifact. For instance, if the patient is a high myope and maybe the machine has a refractive error of, let's say, for instance, I'm giving an instance, -1 to -10, for instance. If the patient's refractive error is somewhere -15, it will show as something that is not normal. Are we together? So this test is a normative test, in the sense that it is comparing your own data with that of your age grade or those within normal limits. Also, another component is the bell curve. In the bell curve, green color means 95% of individuals will have that retinal nerve fiber layer thickness, which is normal. Yellow in the bell curve means that only 5% of individuals will have that retinal fiber nerve layer thickness, which is slightly abnormal. And then red color means that only 1% of individuals will have that RFNL thickness, which is danger zone. White color means that the patient's value is thicker than 95% of the age-matched control group. So if you are seeing white in the bell curve, it means that this patient even scored above normal. The patient had above A or A. And then this color coding does not apply to the RFNL thickness map. Remember, I told you earlier that in the RNFL thickness map, red is signifying that it is normal. But here now, red means that only 1% of the individuals will have that RFNL thickness map, which is danger zone. Are we together? Are you with me?
Yeah, we are too,
Yes,
sir.
we are with you.
Okay.
Yes.
The
Yes, we are
sixth
with you.
component is the RNFL tabular data. It is a summary of the data gotten from the measurements of the RFNN from the circular tomogram. Don't worry, don't bother about all these terminologies. I just want you to get the basic. So the more you practice, the more you bring up cases, the more all these things I'm saying will begin to align and make sense to you. Also, it compares the symmetry of the right eye and the left eye. It uses a background color to indicate the statistical importance of this number. So this is image of a normal RNFL tabular data. So when you are seeing green, it means that it is normal. White means above normal. And when you see gray, gray means that there is no fixed data to show if it is good or bad. So in this place now, we see average RNFL thickness, and it's saying it is 88 and 87. So this green is showing that this number here is within the normal limits. If it were to be red, it will mean that something is wrong. Our NFL symmetry is showing 95 for both eyes, which means it is within normal limits. The rim area is 1.28 millimeter square, and here is 1.11 for the left eye. It shows that it is within normal limits. There's a limit, there's a range for every of these data. And then the disc area, which is gray, like I told you, when you see gray, it means that there is nothing, there is no normal. It is different for different individuals. Are we together? And then the average cup to disc ratio, 0.6. But remember that in your ophthalmoscopy, 0.1 to 0.4 is a normal. But this case now is saying that 0.6 is a normal cupping. So this can be a case of physiological cupping. And this is the average cup to disc ratio, and then this is the vertical cup to disc ratio, which is 0.5 and 0.62, which is also normal for this patient. And then the cup volume is 0.221 on the right eye and 0.268 on the left eye. The seventh component of the scan is the RNFL pie charts. There are two pie charts showing the same RNL tomogram data in separate ways. The first divides the data into quadrants, while the second divides the same data into clock hours. I'm going to explain that shortly. The first pie chart shows diffuse changes, while the second pie chart shows focal changes. The combination of them limits the risk of overcalling a disease. The color coding of RNFN tabular data is also used here. So this is what I mean. Now, this is the first pie chart. It divides it into 4 quadrants. This is the superior, inferior, temporal, and nasal. And then you can see some numbers around it. Here is 106 for the superior, 63 for the nasal, 107 for the inferior, 74 for the temporal. Now, this second pie chart now divides it into clock hours. So this first one above is like a diffuse, or sorry, a generalized pie chart. And now this is more detailed. So in the sense that we want to know what is going on in every segment. You can see that it has several lines demarcating it. So if you add these 3 numbers here and divide it by 3, you'll get 106. If you add 84, 50, and 56, divided by 3, you will get 63. If you add 150, 105, 65, and divide it by 3, you will get 107. If you add 78, 55, 89, and divide them by 3, you still get 74. So both of them are the same thing, just that this is more detailed. It's showing us that, oh, something can be wrong here, and then when you check your nasal in this diffuse here, nasal can be showing green, but here it can show you yellow or red, showing that in as much as generally this whole nasal part might be healthy, but there's something going on in a particular quadrant. Are we together? Are you with me?
Yes.
So this is an example of what I mean.
Yes.
Now, this is a generalized pie chart. This is the superior, inferior, temporal, and nasal. And this is 78, 45, 69, and 44. Now, if you look at this part now, you find out that some parts are red, some are yellow, some are green. Green signifies that that place is very healthy. Yellow signifies that something is going on. And red signifies that there's a loss there. So if you look at this chart, these two charts now, you find out that everywhere here is red. The superior here is red. But when we look at the superior here, you find out that the damage is more in these two parts than in this part. Are you seeing where my cursor is?
Yes.
Also, if you look at this part now, it's showing that the superior, temporal, and inferior are, the fibers there are lost, but the nasal is still a little bit healthy. So when we look at the nasal, you find out that this point is green, showing that here is more healthy than this place. So do you understand what we are trying to say when we talk about the pie chart?
Yes.
Okay. So let me go to the next point. Remember, this is just a basic slide on OCT. There are also advanced slides on them, but we need to focus more on the basics before we go to the advanced. I'm sure most of you already know what I'm talking about, so I'm just trying to refresh your memory. The next component is the TSNT map, also called TSNIT. It is pronounced TSNIT, but it means temporal, superior, nasal, temporal map. This represents a graphical plot of the RNFL for each point. It measures from the temporal retina to the superior, to the nasal, to the inferior, and back to the temporal. So in other words, it's going in a circular manner. So it begins to take measurements from the temporal, then up to the superior, then to the nasal, and then down to the inferior, and back to the temporal retina. It is used to detect a localized defect or extensive flattening. Normal results should have an increased thickness at the superior and inferior pole than the nasal and inferior pole. Remember in glaucoma, remember your easing through the ISNT. And also we say that glaucoma affects more of the superior and inferior temporal fibers. This increased thickness is referred to as a double hump sign. So this is what we call the double hump sign, this place here and this place here. So you see that there's a hump here as if like a hunchback and a hunchback. So this is what we call the double hump sign. So this, remember again, this is a graphical plot of the RNFL. Now, when you see a case like this, what is it trying to say? You are seeing two lines here. One is dotted. Can you see the dotted line?
Yes, yes, we can.
And
Yeah.
then there's another
Yeah, we
one that
can
is
see
just
it.
straight. Can you see there are two lines there? One is
Yes, we can
dotted, one
see
is
it.
not.
Yes.
So the one that is not dotted is for the right eye, and the one that is dotted is for the left eye. So what this is trying to tell us that for the right eye, you can see that there are three colors here. There is green here, there is yellow, and there is red. Now, for healthy results, these lines should not cross over into the red, this red part here. At some point, they might be wanting to touch the yellow one, and we can ignore it, but then they should never enter into the red part. Are we together? Remember what I told you earlier on the RNFL? Do you remember? So the straight lines or the one that are not dotted is indicative of the right eye. And if you see the right eye, it is in the green part, showing that there is no, the thickness is still intact. Now let's look for the dotted lines. The dotted lines also in the green part. But then if you check at this point, I see where my cursor is. At this point, as if it dipped into the yellow part. For those who are into forex, we call it a bearish run, right? So as if it's going down into the yellow part, but then it went up again. And then, so this is a healthy RNFL thickness. Are we together?
Yes.
So what
Yes.
I'm saying is
Yes.
that these two lines should remain in the green part, at most touch the yellow. But when it enters the red part, it's showing that something is wrong. And now, if you see here, this temp is temporal. SUP is superior. Here is nasal. Here is inferior, and this is temporal. So this is showing us that this is the temporal part of the retina. So in this part, it is still thick. The superior, it is still thick. Now the nasal, if you see in the nasal, as if it was coming down, did you notice it? Did you notice this line as if it's coming down in the nasal,
Yes.
this nasal part?
Yes.
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 So
Yes.
remember,
Yes.
in glaucoma, will usually affect the superior and then the temporal. Are we together? But then it didn't enter the red part, right? And then the inferior, it went up again. Over to the next slide. Now, this is an image of an abnormal RNFL graph. Now, in this place, this is the temporal part. It is all going well. Remember, the straight line is for the right eye, sorry, and the dotted line is for the left eye. Now, at this point, everything seems to be fine. Then when we get to the superior part, did you notice that the dotted line entered the yellow part? Did you notice it?
Yes.
Did you also notice that at this point it touched the
The
red
red.
part?
Yes, sir.
Yes. Yes.
Yes.
Now look at it again. Now look at this point now. Did you notice that in the inferior part, the dotted line touched the red part?
Yes.
Yes.
And the
Yes.
dotted line for which eye? The left eye,
The
right?
left eye. Yes.
So you find out that there's something wrong with the left eye. And also, if you see the right eye too, it entered too, right?
Yes.
Yes, sir.
But it didn't enter here.
Yes.
So which
Yes,
means
sir.
for both eyes, inferiorly, something is going on here. Do you understand?
Yes.
You understand?
Yes.
Yes. Yes.
Okay. Let's
Yes.
go to the next component. So the thickness graph of the neuroretinal rim, this is another component of the scan. It measures the thickness of the NRR, which is the neuroretinal rim. And I've told you that the neuroretinal rim is the distance between this margin and the cup margin. So it measures the thickness of that area. The measurement is taken along the opening of the Brooks membrane. The Brooks membrane is, in a layman terms now, is part of the layers of the retina, but it separates the choroid from the retina. Are we together? And then
Yes.
it takes the distance between the internal limiting membrane and the Brooks membrane to get the rim width. I'll explain that later. And then it helps us to detect localized notch. That one I'm going to explain it, even if you don't understand what I'm talking about. Now, this is an image of a normal discrete graph. Discrete means temporal, superior, nasal, inferior, and temporal graph of the neuroretinal rim. So this image is normal. So this line here, this line now, is it for the right eye or for the left eye? The straight
Right.
line.
Right.
Right.
Eh?
Right eye.
What of the
Right.
dotted line?
Left.
Left.
Okay, good, you are following me. So you can see that the for the right eye is even above limit. Are you seeing it?
Yes.
It's
Yes.
above the
Yes.
green part. So which means the right eye is healthy. For the left eye, it's still within normal limits. It's not as good as the right eye, but still it's still within the normal limits. For the left eye, it's still in the green part. Are we together?
Yes.
Now let's go to this now. Now this is image of an abnormal discrete graph of the neuroretinal rim. Now, if you look at this now, you find out that in this point, it started well. But when we got to the superior part, it entered into the red part. Are you noticing it?
Yes.
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 Now, when we now get to the nasal part, at this region, the space between the nasal and the inferior, it is okay. Also, the temporal is okay. But you see this part, something is wrong here. So, there's a loss in the neuroretinal rim. Are we together?
Yes.
Okay.
Hope you are following me to this
Eh,
point.
there's no
Yes.
left eye here.
But there's no
Yes.
left.
This is just for
Okay.
OD. See it written here, OD.
Okay.
You see OD here?
Yes.
Yeah.
So your OCT might have it as OD and OS, or you might have it as just, so when you now see two lines, you know that it's talking about the dotted line will now be for the left eye and the straight line will be for the right eye. Are we together?
Yes.
Yes.
Okay. So another component of the scan is the extracted horizontal and vertical B scan. It determines the boundary of the disc and cup. The B scan is done in the horizontal and vertical direction by scanning the internal limiting membrane and the Brooks membrane. So this is a diagram of the B-scan, image of the extracted horizontal and vertical B-scan. This is the horizontal B-scan, and this is the horizontal B-scan. So what I'm trying to say is that for the machine to get where your optic disc is, it will first of all find where your Brooks membrane should be somewhere around here. It will first of all find it, and then the machine automatically counts some millimeters above to get this point, which is your internal limiting membrane, and then from there it finds where the patient's optic disc is. That's what we're trying to talk about here. Also, the 11th component of the scan is RNFL calculation cycle or cycle B-scan. It's a reliable criterion to confirm good centering. It tells us about the segmentation of the retinal layers by the software. It searches for errors of segmentation or localized signal loss despite good signal strength. So the signal strength can be good, but maybe the patient was not properly aligned, and then the machine wants to read it as a bad result. So this calculation signal bypasses those kind of errors. Are we together? Abnormal B-scan is due to machine failure, and the scan should be repeated. So when you see abnormal cycle B-scan, is due to error of the machine, and then the scan should be repeated. This is an image of the circular B-scan. I know it might not be so clear, but if you have an OCT result with you, you'll be able to appreciate the image of the circular B-scan. Now, there's what we call red disease in OCT. Red disease is a phenomenon. This is a term used to denote a false positive OCT scan. So in this case, a patient is diagnosed of having glaucoma based on the red boxes in the statistical analysis. Careful analysis will reveal this to either be wrong interpretation or a case of a glaucoma suspect with a normal visual field. High myopia, tilted disc, temporal displacement of RNFL peaks from cyclotorsion. So you know what cyclotortion is? An upward and outward deviation of the eyes, right?
Yes.
Media opacities, pathologies are the common cause of artifacts in healthy patients. So when you have, remember I told you earlier that myopia can also affect the results. So just in case the machine does not have, for instance, let me give you an instance. If the machine has an inbuilt data inside of it, and then the machine has a range of, okay, let's say from -1 to -20, it has the data of what their OCT result will look like. And then you are now seeing a patient of -25 or 30, for instance. It will appear as a rare disease because the machine does not have that data inside of it. Do you understand?
Yes.
So high myopia, tilted disc, temporal displacement of RFNL, peaks from cyclotorsion, media opacities, pathologies are common cause of artifacts in healthy patients. Green disease, this is a term to denote a false negative OCT scan. It is seen in early glaucoma. Occurs when RFNL and optic parameters are asymmetric in both eyes. Axonal edema, optic uveitis, acute ischemia, and short-term intracranial hypertension are common causes of green disease. So in green disease, this is what are the common causes. Now, optic nerve head analysis. Remember I told you that in OCT we can also analyze the optic nerve head. So glaucoma leads to ganglion cell loss, which will lead to thinning of the neuroretinal rim. Thinning of the NRR will result to increased cupping. So every time you are seeing increased cupping, it's because there is a thinning of the neuroretinal rim. This scan is composed of 6 linear scans in a spoke pattern demarcated by 30-degree interval. Ganglion cell analysis. There are projection neurons. So the ganglion cells are projection neurons conveying information from the retina to the brain. Glaucoma damages the thickness of the ganglion cells, resulting in gradual visual vision loss, never sudden. Remember I told you that glaucoma is not a sudden vision loss. So just that the patient will notice it after when so much damage has been done. But glaucoma usually is not sudden, so it is a gradual loss. So glaucoma damages the thickness of the ganglion cell, resulting in gradual vision loss. The scan images to assess the overall macular thickness, asymmetry between the two eyes, and progression over time. Accurate patterns of RNFL loss can be seen from the macula to the optic nerve head. In cases where the changes to the RNFF is not significant, macular analysis is a superior diagnostic indicator. So what we're trying to say that the macular analysis is superior to the ganglion cell analysis. And then in the ganglion cell analysis, there is the the Cyrus machine measures the ganglion cell complex, which is made up of nerve fiber layers plus the ganglion cell layer plus inner plexiform layer. Then the optoview is another kind of machine. The altiview measures ganglion cell analysis. There is ganglion cell plus just and the inner plexiform layer. While the calzis will include the nerve fiber layer, ganglion cell layer, and inner plexiform layer. Are we together? So the following are observed in the printout. The same data we observe in the RNFL. We also observe it here. The patient's data, the signal strength, the thickness. I've told you what signal strength is. The thickness mark with blue color signifying thinning of the cells. Any lesions are more marked in the temporal area. Macular deviation maps with red color signifying thinning. Tables for parameters represented in pie charts, specific parameters, and then the horizontal B-scan. So this is an image of a normal ganglion cell. So here now, you can see the color coding here. There's red, pink, yellow, green, and black. So anything from the blue down to black is indicating a loss. So we are more after this cycle, what's happening inside this cycle. So you see that in this cycle, there is a color of yellow and red here, which is showing that the color coding here is normal. So I want you to, in this OCT, I don't want you to just assume that every time you see red, it is bad or it is good. Always make reference to the color coding here, because what is obtainable here might not be obtainable in the RFN thickness map. You understand? So always make reference to the coding here to know if the color here is good. Now you will also notice that the center here is blue. Did you notice it? And a bit of black. Have you noticed it?
Yes.
So it is normal for every patient. I want you to find out why is it normal. So one of your take-home assignments, why is it normal here? There's a reason why this place is blue and black and it's still normal. Meanwhile, we are saying that when we are seeing blue here, it is wrong. Something is going on here. But why is this place blue and black and it's normal? I want you to find out and give me feedback. So now this is the deviation map. Remember, the deviation map is comparing whatever the patient has with his age grade. So, and in the deviation map, when you see a clear color or whitish color or grayish color, it's indicating that everything is okay. And then when you see yellow or red, yellow indicates that something is going, but it is minor, and red indicates that something serious is happening. And how do I know? I can see it from this chart here. Yeah, white indicates 95%, which is normal. Green indicates 5%. Yellow is okay. No, white is above normal. The green is for the 95%. The yellow is for the 5%, and the one is for the 1% is for the red color here. So if you look at this pie chart here, you find out that this place is white in color. Have you seen it? White here is green in color. Can you appreciate it?
Yes.
So the white here means that this place is above normal. This is a healthy result, remember. And green here indicates that everything here is also within normal. Just that this place is more healthy. It is anything like more healthy than this place. While also for the left eye, you find out that here is white, also indicates that this place are healthy. Also the green also indicates that they are healthy, just that the white shows that it's more healthy than the green part. So also here, there's a table here. Average GCL plus IPL thickness is 94 for the right eye, 94 for the left eye. And if you notice, the 94 is inside a green box. Do you remember the table I told you earlier that when we see a green box, it means it is normal? If here were to be red, this value will be less than this. If this box were to be red, this value will be less than this, and it will show that something is wrong. Now, minimum GCL plus IPL thickness, 91 and 86, within normal limits. Are we together?
Yes.
And then this is the horizontal B scan and the OS for the left eye horizontal B scan.
Please look at that upper picture.
Okay.
The upper picture by your right hand side, I mean that's the OS. Temporally, there's a difference between that and the right eye. No, move your cursor. Temporally,
Now,
yes, I
this
noticed that.
place, right? Now, did you
Yes.
notice that there's a color 2 here?
Okay.
I think that these two must match or should match because you can see that there's a loss here and then OCT captured it here,
Yellow.
showing that
Yes.
it is still minor, but then even though it's minor, the OCT can still capture it.
Okay.
This is why OCT is the boss.
Okay.
Now, this is an image of an abnormal ganglion cell result. So we are seeing again that you can see that there is yellow here and you are seeing blue here. Remember, look at your color coding and know if red is normal and if blue is abnormal. So here showing that blue is abnormal and we are seeing blue here. So there's a loss here. And then remember I told you that the color coding for this and this are not the same. The color coding for the deviation map and the actual map are not the same. They are opposite. In this place, red means normal. In this place, which is the deviation map, red means abnormal. But if you note, the pattern here is the same pattern here. Have you noticed it?
Yes.
So, but some parts are yellow. Have you seen some parts are yellow here? Also, if you look at this place, some parts in this green part, some parts are yellow. Those are the blue parts. So it's showing that there's a loss in the ganglion cell here. I know glaucoma affects the ganglion cell. Also, if you check this place too, you see that there's a loss here, which is also in line with this loss we are seeing here. And then when we come to this table here, everything here is red, right?
Yes.
Right. But the previous one we saw earlier was green. So the red itself is an alarm telling you that something is wrong. Now, if you look at the pie chart here, you find out that this place is red, here is green. This place is red, here is green. So this red is showing a loss. And you can see it here too. You can see it here too. Green, healthy. You can see it here. You can see it here. You can see a loss in this red. You can see it here. You can also see it here. Now, over to the macular thickness. Several diseases, not just glaucoma, can affect the macular thickness. A thinning of the macula will definitely reduce vision and pupillation. The color coding in the thickness map gives a quick insight into the overall health of the macula. So this is a normal macular thickness, and then you can see that everything is green in color. So it's just a quick one and show you that everything here is healthy. And then this is the layers of the retina. This is the fovea. This is the fovea. And then your normal retina, there's a depression in the fovea. It's normal. So this is a normal macular thickness. Over to retinal analysis. The retina is responsible for sending, we are done with glaucoma analysis. So we want to, remember I told you that OCT is not just for detecting and grading the extent of visual loss in glaucoma. We can also use it to check the retina, examine the retina, and diagnose pathologies in the retina. So we are now over to retina analysis. So, and again, I want you to know that the retinal analysis is very, very complex. There are a whole lot of pathologies that my work here cannot capture all of them. If I capture all of them, we might not live today. So I'll just capture basic things, and maybe when we now go into the advanced class, we'll now begin to go more into retinal pathologies and how to identify everything we see and say, okay, this is diabetic retinopathy, this is diabetic, this is edema, this is this and that. But for the sake of this lecture, I want to be as basic as possible. I won't go into complex retinal pathologies. Are you with me?
Yes.
So the retina is responsible for sending signals to the brain. It cannot regenerate. So even though research is going on how they can regenerate the retina, I think I did the research on that. That was last year, and the scientists who gave the lecture, they were saying that there's a drug that can be injected into the retina, and then the retina can regenerate. And I think they were taking lessons from why the lizard and other animals in this grade can regenerate their body, and they are studying them and see how they can apply it to the human retina. So research is going on, and hopefully one day they can regenerate the retina. But for now, the retina cannot regenerate. It's made up of 10 layers. Highly reflective structures are shown in bright colors, white and red. Lowly reflective colors are represented by dark colors, black and blue. Intermediate reflectivity is shown in green. So these are the layers of the retina. So in your free time, you just note them from top to bottom. So you can see how the nerve fiber layer, ganglion cell layer, inner plexiform, inner nuclear, outer plexiform. So they are all graded here. When we share the materials or the slide, you can on your own spare time and study them. So this is the book membrane complex I told you about that separates the retina from the choroid. So this part is the choroid. So that is that for that. And this is the OCT image of the retina. So this is the vitreous, this is the nerve fiber layer, this is the fovea. Remember the depression is the fovea. But what then happens? Let me throw a question to us. What happens, or what will you say if you don't see a depression like this? What do you think is the condition? When you don't see a depression on the fovea. A quick one, what do you think? A normal fovea, there will be a depression. But what if you don't see a depression here? What do you think is likely to be the cause?
Edema.
Eh?
Edema.
Edema.
Yes.
Okay, what else again?
Um,
What of epiretinal membrane?
ERM.
Okay, so there are scholars here too who understand what I'm talking about. So I'm just here to refresh your memory on OCT. So this is the retinal pigment epithelium, and then this is the choroid. So who can tell me, is this what type of OCT is this? Is this a spectral domain or time domain? From this picture you are seeing here.
Spectrum.
Why do you say spectrum? Okay, just that'll be later you find out what it is. Now this is how I'm just going to be showing you some pathologies so that you can be able to do a quick analysis. Then when I begin the advanced class, then I will tell you how and why we can say this is a cystoid macular edema, because you should be able to note where this edema is coming from, which layer of the retina. I'll talk about that in the advanced class. So this is how cystoid macular edema looks like. You can see this space here. There are spaces here. This is a graphical or a typical example of cystoid macular edema. The macular cyst. This is how a macular cyst. Remember I told you that in the fovea there is a depression. But if you notice here, there's like something covering it here. Can you see this layer here?
Yes.
So this is what a macular cyst looks like. This is what macular edema looks like. So you can see that there's a swelling here, an accumulation of fluid here. So maybe in advanced classes, we will now relate this to how we can use the pathology here to find better treatment plans. This is what we call macular pucker. Macular pucker is a membrane over the fovea. So you can see that the depression here is not that obvious. So this is what we call macular pucker. Don't worry, in the advanced class, I will talk more on retinal pathologies. This is how a retinal detachment will look like in your OCT. So is this a partial or a total detachment? Is this a partial detachment or a total detachment?
Yeah.
I think it's a partial detachment.
Correct. It's a partial detachment.
Partial.
So you can see that it is detached up to this point. And you need to know what point is this. So we'll talk about that in advanced class. What point is this? what layer of the retina is this? So this is a partial retinal detachment. So this is how diabetic macular edema with intraretinal edema look like. So this is what we call subretinal fluid. This subretinal fluid. These are intraretinal fluids. So a doctor, a general practitioner might be managing a patient for diabetes, assuming the patient has diabetes for, let's say, 20, 25 years or 15 years. He can send to your clinic for OCT. So it is now your duty to interpret it to the general doctor, saying that this is what we are seeing. This is what is happening in the patient. So these are signs of diabetic macular edema with intraretinal edema. Are we together? And this is a case of age-related macular degeneration. So this is how it will look like. But I know you might not be able to pinpoint which is which for now. But don't worry, in the advanced class, we will now look at how we are able to know that this is age-related macular degeneration and not cystoid macular edema. So this is just a quick overview on OCT. Remember, this is a basic class. We expect everyone to be at speed with this. If you know these basics, then you can now be able to go into the complex matters. So OCT has come to stay. It is the pride of optometry. OCT is the pride of optometry, and this is where it's moving to. So everyone should know what OCT is, know what it is used for, and be able to do a quick interpretation. Are we together? So OCT is a vast field, not only limited to ocular anomalies. Other branches of medicine are beginning to embrace this field to have insight into the general body pathology. What is obtainable today might not be the case in 3 years' time. Hence, the need for continuous research, hunger, and quest for knowledge. Keep making progress. Thank you, and God bless you.
Wow, that was
Thank
really,
you.
really good. Thank you so much, Dr. Wisdom.
Thank you, Dr.
Thank
Wisdom.
you. Thank you.
Thank you so much, Dr. Wisdom. That was really, really good. Hope everyone came today.
Yes.
Yes. I really wanted her to continue though, but I guess there is time for everything. Please, do we have any questions? Do you have any questions we would like to be clarified? Any questions?
Okay. You made mention somewhere that glaucoma affects the superior fibers and inferior fibers. I wanted to be clear on that.
Okay. What actually is your question?
Okay, my question is it the superior and inferior fibers? Because I
Okay.
heard somewhere that it's
Some, the retinal nerve fiber layer has an arrangement. There is the superior temporal fiber, inferior temporal fiber, superior radiating fiber, inferior radiating fiber. So the superior arcuate fibers and the inferior arcuate fibers are more susceptible to glaucoma damage. You understand? They are the ones that will be affected first when there is glaucoma. So likely we will see them first in the OCT. You understand what I'm talking about?
okay.
It's just like in a room of people where you have two bodybuilders and two people who are not bodybuilders. So those who are not bodybuilders might not be able to withstand so much pressure if they are lifting a weight because they are not as strong as the bodybuilders. You understand?
Okay.
So the superior arcuate fiber and the inferior arcuate fiber, which are temporal fibers, are more susceptible to glaucoma damage than the papillomacular bundle and the radiating fibers.
Okay. I think that's better now.
Okay.
Favor, your hand is still up. Do you want to ask any other question?
Yeah, please. What's the difference between a subretinal fluid and intraretinal fluid?
A sub what?
Retinal fluid and intraretinal fluid.
Now, like as the name implies, but even though this is what I want to talk on the next class, not now, but since you asked, a subretinal fluid is below the retinal nerve, the retinal layers. Intra is within the retinal layers. It can be in the ganglion cell, it can be anywhere. But as the name sub means below, and intra means within. You understand? But when we go to the advanced class, we will talk more on this.
So just to add to what Dr. Wisdom just explained now, for an intraretinal edema, it's basically that the edema is in any of the retinal layers. So any of the retinal layers, either the innervesiform or any layer of the retina, the fluid is there. But when we say a subretinal fluid, then the fluid is found between the retina and the choroid. So it's now below the retinal layer. So
Thank you so much, Dr. Wisdom. Since in the absence of no question, we're going to be closing the meeting. We've had an insightful session so far, and we really appreciate you, Dr. Wisdom, for that awesome teaching and insights. And definitely in future cases that we're going to get more of it.